Calcified lesions are a true challenge for interventional cardiologists because we have to kind of get rid of the calcium and be able to crack the calcium, position a stent, and keep in mind that if we deploy a stent in a highly calcified lesion and we don't open up the stent enough, then we may run into trouble. It's very important indeed because you can see the calcium from the inside of the artery, and angiography is important, but of course there are very many details that only intravascular imaging modality can provide us with. So we can see the calcium, we can quantify it, and then we can choose the best weapon in order to open the artery the way we like. I would say that there are two main imaging modality, IVUS and OCT. We are an OCT center, so we tend to use OCT. In terms of calcium, I do prefer OCT because we can have a very knitted assessment of the calcium, and we can measure very easily the thickness of calcium, and we can also apply a score that has been recently validated, taking into account the length of the calcium, the thickness of the calcium, and the circumferential extension of the calcific components. I try to use it before intervention, but I must say that sometimes, if the lesion is very, very calcific, it is difficult to negotiate the lesion with, particularly with OCT now. So sometimes I go in, I try to open the lesion with the device, high pressure dilatation, laser, and shock wave, rota, etc. And then later on, once I have opened the artery, then I do a second attempt, if I could not before, with imaging modality to understand if I was able to crack the plaque and therefore to get to improve the anatomy. No, I don't think so. I mean, sometimes it is difficult to understand what is the amount of calcium. Sometimes we do an angiography, an angioplasty in a lesion that does not seem that calcific, but then we realize that we don't open up the artery very well, and then we have to approach it with imaging modality. So we tend to perform IVUS and OCT guided procedure when there is a lot of calcium. Again, let me stress once more time a very important concept. Our goal is, when there is calcium, is to crack the plaque and to make sure then that when we develop a stent, we obtain a large lumen, which is for sure a key element that gives us a better follow-up.